this video, we will be addressing the pathophysiology behind alcoholic liver disease and the treatments for this, as well as alcohol use disorder. We will also discuss liver-associated drug interactions between alcohol and other drugs, specifically being Tylenol or acetaminophen. So let's start off by talking about what happens in the case of mild to moderate alcohol ingestion. And what will happen is alcohol will travel to the liver to be metabolized and inactivated. So once it's inside hepatocytes, the primary cytosolic metabolic pathway will convert alcohol to acetaldehyde. And the enzyme that is responsible for this is alcohol dehydrogenase. Now, acetaldehyde is the molecule that is responsible for those hangover-like symptoms. And because of its molecular structure, which I'll show you here, it is a very highly reactive and toxic molecule. And it's capable of creating adducts, leading to genomic and cellular damage and depleting antioxidant stores. However, again, in this mild to moderate alcohol consumption, the body quickly metabolizes acetaldehyde to acetic acid via acetaldehyde dehydrogenase, or you might see this just as aldehyde dehydrogenase. And then this acetic acid can be converted to acetyl-CoA by acetyl-CoA synthase, which can then enter the TCA cycle to be used. So now let's contrast this with what happens in the setting of high chronic alcohol consumption. So when large amounts of alcohol are consumed chronically, another pathway is needed to deal with this greater amount of alcohol in the system. And what happens is this is metabolized by this first pathway that we already talked about, but also by a secondary pathway. And this secondary pathway relies upon that CYP450 system of enzymes that we've talked about a little bit before. And specifically for today, we're going to focus on CYP2E1, which can still convert alcohol to that acetaldehyde metabolite. But because now both of these pathways are needed, there is going to be this buildup of acetaldehyde that cannot be funneled through to acetic acid, acetyl-CoA, and so forth. So now that we have this buildup of acetaldehyde that we cannot convert to acetic acid because there's just too much for the system, what ends up happening to it? Because remember, it is a very reactive and toxic molecule. So first, this acetaldehyde can directly cause cytotoxic effects within the liver by covalently binding proteins in DNA, leading to irreversible damage and apoptosis directly. Secondly, the body may attempt to sort of neutralize the acetaldehyde by sending it to the mitochondria to then be conjugated with antioxidants like glutathione. And once this acetaldehyde glutathione conjugate is formed, acetaldehyde loses its reactivity and can be excreted from the body. However, this high alcohol consumption depletes the glutathione stores. And acetaldehyde can also bind and inactivate the enzymes that are even required for this conjugation reaction. This together impairs the hepatocyte's ability to deal with reactive oxygen species because there's no more antioxidants. And this causes damage and leads to apoptosis as well. Another important thing to note as we go through this video is alcohol induces CYP2E1 expression. So with chronic alcohol consumption, this enzyme will be responsible for more and more of alcohol's metabolism. So even more acetaldehyde will be produced. That cannot be funneled through this pathway. Chronic alcohol consumption can also cause liver damage independent of acetaldehyde metabolites. So alcohol has been shown to alter the permeability of the GI epithelium, leading to what's referred to as a leaky gut. This leakiness allows lipopolysaccharides, or LPS, molecules and other components from the gut microbiome to enter into the circulation to then travel to the liver. In the liver, these LPS molecules will be recognized and bound by toll-like receptor 4 or TLR4 receptors that are found on the liver resident macrophages. This recognition activates the immune response in the liver by these resident macrophages releasing a significant amount of tumor necrosis factor alpha, as well as a number of other cytokines that trigger inflammation and apoptosis. But these macrophages will also release IL-8 or interleukin 8 and other chemokines that recruit other immune cells to this site of inflammation to further propagate this inflammatory response and liver damage. So moving to the next slide. So all of these insults together highlight how chronic and high levels of alcohol consumption on its own can trigger significant liver damage. But what about if we throw in other drugs that are capable of inducing hepatotoxicity? So the agent most people think of is acetaminophen, which is the active component of Tylenol, and you will very commonly see it abbreviated as APAP. So moving to the next slide. So I left alcohol's metabolic pathways here just as a reminder, but now we are going to transition to acetaminophen for just a moment. Now, acetaminophen has 3 different hepatic metabolic pathway options. First is through interaction with sulfotransferases, and this leads to a sulfate metabolite that is inactive and non-toxic, and also readily excreted from the body. So the next option is glucuronidation, to form a glucuronide, acetaminophen metabolite that is also inactive, non-toxic, and similarly readily excreted from the body. Now, under normal physiologic conditions, glucuronidation is the main metabolic pathway that acetaminophen will be funneled through. But now let's talk about our last metabolic pathway option, which is CYP2E1. And to a smaller extent, 3A4, but since we're talking about the interaction between alcohol and acetaminophen, we're going to focus on 2E1. Now, CYP2E1 converts acetaminophen to NAPQI, which is an abbreviation for this particular metabolite, which is also known as N-acetyl-parabenzoquinone, which, just like acetaldehyde, is a highly toxic and reactive metabolite. Under normal physiologic conditions, this acetaminophen metabolite NAPQI is produced at a very small amount, and it's readily detoxified in the liver using glutathione conjugation to create a non-toxic metabolite for excretion. Now, I'm sure you can tell where this drug interaction is going. So in the case of alcohol use disorder, CYP2E1 is significantly induced. And remember, glutathione stores are depleted because of this acetaldehyde abundance. So now, if alcohol and acetaminophen are taken together at the same time, alcohol is going to be in such excess that it's going to take up all of the CYP2E1 binding sites. So it will competitively inhibit this formation of NAPQI, and it will funnel acetaminophen through one of these 2 pathways instead. So in the setting of acute intoxication, alcohol is actually protective against NAPQI formation. Obviously, this abundance of acetaldehyde formation has its own issues, but NAPQI is not what's being formed. So the real issue becomes when the chronic heavy drinker is not intoxicated, so alcohol is not on board. So this alcohol isn't taking up all of those CYP2E1 enzyme sites. But because there is so much more CYP2E1 available because of this induction, acetaminophen is funneled through this metabolic pathway predominantly, leading to a significant increase in the amount of NAPQI metabolites. But remember, glutathione stores are still depleted. because of the chronic alcohol consumption. So now NAPQI accumulates to then elicit its reactive and toxic effects to cause liver damage and inflammation in a similar way that acetaldehyde would induce the same effects on the previous slide. So by impairing the hepatocyte's ability to deal with reactive oxygen species, as well as directly leading to adducts on cellular and genomic components to elicit apoptosis. And in the setting of an acetaminophen overdose, this is why glutathione stores have to be repleted with N-acetylcysteine, which will replete these glutathione stores to then prevent further liver damage. So moving to the next slide. The risk of hepatotoxicity is why there is a daily dosing limit for acetaminophen. And acetaminophen should not be taken in patients with liver disease, or it may require dosing adjustments in more mild to moderate liver disease. And patients should always consult with their doctors before using Tylenol regularly if they drink more than 3 alcoholic drinks per day. So this points to a key counseling point regarding the treatment and management of alcoholic liver disease, which is to ensure your patients understand the risks associated with alcohol, acetaminophen, and other potentially hepatotoxic agents. So let's continue to discuss agents that are actually used to manage alcoholic liver disease and alcohol use disorder. So moving to the next slide. So in addition to avoiding or dose adjusting hepatotoxic agents, there are a few pharmacologic treatments available to help manage alcoholic liver disease, but one of the most important treatments is of their alcohol use disorder and abstinence from alcohol consumption. So there are 3 FDA-approved therapies available to help with this. First up is disulfiram. And disulfiram is an irreversible inhibitor of acetaldehyde dehydrogenase. So it prevents this conversion of acetaldehyde to acetic acid, which will lead to a buildup of acetaldehyde to trigger the nausea and vomiting and other hangover symptoms following alcohol ingestion. And ideally, this unpleasant reaction will deter future alcohol consumption. As you can imagine, before this therapy can be used, a patient must have had a period where they have abstained from alcohol ingestion to allow time for this repletion of the glutathione stores to be able to handle these acute increases in acetaldehyde levels. Otherwise, this could be even more hepatotoxic to their already likely damaged liver. So an added bonus is disulfiram has also been shown to inhibit CYP2E1 to prevent a sort of large acetaldehyde spike. So it's just enough to trigger that sort of nausea, vomiting, and not feeling well. So as you can imagine, this induction of nausea and vomiting, though, with alcohol consumption may not be a great fit for elderly patients or those with a number of comorbid conditions. So the applicability of this treatment is limited to particular patient populations. The next agent we'll discuss is naltrexone. And naltrexone is a mu opioid receptor antagonist. High alcohol consumption is associated with endogenous opioid activity in the CNS. So alterations in opioid receptor activity and signaling through opiate antagonism with naltrexone leads to inhibitory effects that's thought to decrease alcohol cravings and consumption. So this option is generally well tolerated, but there are concerns of liver enzyme elevations and hepatotoxicity, so hepatic monitoring is required. Our last option we'll talk about is acamprosate. And acamprosate is a GABA receptor agonist. Just like naltrexone and the opioid receptors, the GABAergic system in the CNS is involved in the modulation of alcohol cravings and intake. And agonism at GABA receptors leads to inhibitory effects, leading to a similar modulatory effect on alcohol cravings and consumption, just like naltrexone. So now that the management of alcohol use disorder is in place, let's talk about measures to help with alcoholic liver disease. As you might expect, with the high degree of inflammation triggered in this cascade, corticosteroids, specifically prednisolone, will play a pivotal role. Again, corticosteroids are not specific alcoholic liver disease treatments, so we won't get into the detail of their mechanism of action, side effects, long-term effects, etc. just yet, but no, they are very effective in producing anti-inflammatory effects, but they should not be used long-term. And we will get into this in a video later on in this block. So pentoxifylline is the last agent we are going to talk about today. And it is used for the treatment of alcoholic liver disease. And this agent is a non-selective phosphodiesterase inhibitor. And phosphodiesterase is an enzyme that's responsible for degrading secondary messengers, primarily cyclic nucleotides, and the focus for alcoholic liver disease will be cyclic AMP. So cyclic AMP degradation by phosphodiesterase generally terminates the signal being produced, and this is an important signaling molecule in immune cells. And when pentoxifylline is on board, this inhibited phosphodiesterase activity leads to prolonged cyclic AMP signaling that triggers a reduction in tumor necrosis factor alpha secretion from those liver resident macrophages, which is that key cytokine involved in triggering inflammation in the liver. And this inhibition of TNF alpha release also impairs the chemotaxis of other immune cells to the liver to further propagate that liver damage. So while this mechanism of action is encouraging, the studies with pentoxifylline are pretty limited. So moving on to our last slide. So in summary, avoidance or dose adjustments of hepatotoxic agents is key for patients with alcoholic liver disease like acetaminophen. Also, abstinence from alcohol with the potential help of naltrexone, acamprosate, or disulfiram is just as important. And to help with the inflammatory pathology behind alcoholic liver disease, prednisolone or pentoxifylline are treatment options. So together, these agents and counseling points we discussed today outline the pharmacologic management of alcoholic liver disease and alcohol use disorder.